Next session, complications prevention management. The first speaker would be Dr. Satish Sheth, sir. He is associate professor of KIMS Hubli, a very good teacher and co-founder of Innovation Medical Optics. He has won many awards and for his scientific papers and videos. He would be speaking on wound construction issues. Over to Dr. Satish Sheth, sir.
At the outset, I wish to thank Dr. M.S. Ravindra, the chairperson, Dr. L.N. Kumaran, scientific committee chairman, for giving me this opportunity. Today, I will be discussing about the wound construction issues in small incision cataract surgery. If you look at this slide, where a sclerocorneal incision earlier no doubt had the advantages of minimal astigmatism and better resistance to both internal and external pressures. But the disadvantages of large conjunctival aperture, the brittle suture, cannot be done under topical anesthesia, diathermy is necessary, are no more disadvantages in the present era of the smaller incisions and the use of foldable IOLs. The internal incision is very, very important, where the initial entry should be parallel to the external incision and the limbus. If the entry is not parallel to the external incision, the internal incision will run in the wrong direction. If the internal incision extends to the sclera, the corneal valve is lost. Now I will be showing you a small animation as to how a crescent blade is being used in carving out a good corneoscleral tunnel. The bevel is there. The heel should be down in the cornea and up in the sclera. So if you take a scleral incision here, heel up in the sclera and heel down in the cornea will give you a good corneoscleral tunnel. And when this fails, it can cause a buttonhole or a premature entry. A good tunnel is performed as far back, at least about 1.5 to 2 millimeters into the sclera. A frown incision is preferred. A partial thickness groove is made, and with a scleral holding forceps, you can slowly make the incision larger to about 1 to 1.5 millimeter into the clear cornea, and the plane has to be maintained throughout on either sides. Depending upon the incision, which can be classified as the corneal, limbal, scleral, or corneoscleral, one thing is important to be noted is that astigmatism decreases as the incision moves from the clear cornea to the sclera. The length of the incision varies anywhere from 1 millimeter to 6.5 millimeter, depending on the IOL to be implanted. Insertion with a forceps or injector, it widens the incision by about 10%. And the astigmatically neutral incisions are 4.5 millimeter sclerocorneal incisions and about 4 millimeter corneal or near corneal incisions. The scleral incisions can be convex, straight, from chevron, J-shaped, or trapezoid, but all these incisions are made in the astigmatically neutral funnel, and chevron incision is supposed to induce the least astigmatism of all the incisions. Now coming to the classification of incision, depending upon the shape, it can be a single plane, biplanar, triplanar, or hinged incision. And These are the results of the type of corneal incision where the valvular action and the astigmatism go together, where the hinged incision is supposed to have the best valve action, but we can also plan triplanar or a biplanar incision than a uniplanar incision. So the limbal incision is the external incision that is made 0.5 mm posterior to the vascular arcade. It has got the advantages of clear corneal incision, induces less astigmatism, it heals more rapidly, causes less discomfort, and resistant to pressure is more compared to corneal incision. The disadvantages are ballooning of the conjunctiva, bleeding into the tunnel, or subconjunctival hemorrhage. The clear corneal incision, the disadvantages are it can cause a leakage which can cause hypotony, prone to endophthalmitis, relatively high astigmatism, early rise of IOP, and slower healing. Now coming to the side port configuration, I'll be sharing another animation here where the side port is performed always in the clear cornea, and preferably a square incision is ideal, and even it can be a rectangular one. The side port should be just inside the limbus, and when you inject the fluid into the side port, it should be injected once the cannula is totally seen in the antechamber and not midway because of the risk of DM detachment. So the fluid or visco should be injected only after entering the antechamber and not when the cannula is in the substance of the cornea. So you can watch that the fluid is injected there. And now I'll show you certain case scenarios where the corneoscleral tunnel, though appears normal, are fraught with complications. One is a small tunnel that has been made. So here the nucleus gets stuck into the corneoscleral tunnel because of the smaller size wound, even though the corneoscleral tunnel looks normal. And then you extend the tunnel on either side and the nucleus can easily come out. And now coming to the tunnel flap here, where the surgeon is more comfortable doing the tunnel in a uniform plane, but once it comes to the lateral end, the tunnel is cut through.
Hello. Hello.
Yes,
Karthik, yes.
Karthik. Can you play
Yes.
the
What happened? Hello?
next video?
Yes,
Can you
doctor.
play?
Yes, doctor.
Is that over, Karthik?
It's over.
It's over, huh? There was some
Yeah,
disturbance. Sir.
yes, sir. It's over. I will playing the next video. Dr.
Okay,
Deepti.
okay. Yeah, yeah. Sorry for this one. The next speaker is Dr. Deepti Meda. She is speaking on endothelial trauma in SSCS. She is the senior consultant at Karthik Netralaya, heading cornea and refractive services. Over to Dr. Deepti.
A very good evening. So today let's go through the causes of endothelial trauma and corneal edema post SICS. So these are the topics that I would be covering with. So coming to the etiology, this is a very good paper by Dr. Namrata Sharma where they have nicely displayed the preoperative, intraoperative and postoperative common causes of corneal edema post phacoemulsification. So the pre and post remain the same even for SICS. So, preoperatively, any sort of endothelial dystrophy is a risk factor for corneal edema. There are few common diseases of the eye where you have to be careful as the endothelium may be compromised, like in a case of pseudoexfoliation, chronic uveitis with the long-standing inflammation, chronic angle closure glaucoma, and any sort of trauma to the corneal edema. And post-operative, anything in the anterior chamber other than the aqueous is a risk factor for edema. May it be vitreous, any sort of medications that has been left behind, IOL loop which is touching, or cortex or nucleus matter, etc. TAS again is a very special entity which can cause limbus to limbus corneal edema and shall be discussed. And again, any sort of post-operative inflammation can cause post-operative damage to the endothelium. Now, coming to the intraoperative causes of SICS, basically the biggest advantage is there is no phaco energy in SICS. Excessive surgical manipulation from the time of tunnel to the prolapse to the IOL is again a big risk factor. Any sort of endothelial touch from the nucleus, IOL instruments, even a misdirected fluid jet onto the endothelium and touch of the vitreous can cause endothelial insult. And even a perfectly performed surgery, if very long, can cause endothelial insults. Now, clinical assessment, there is a frank and an obvious loss of corneal sheen and luster and transparency. There is this crisscross corneal and Descemet's membrane folds or the striae keratopathy. There is always an associated corneal thickening. Also, do look for other associated signs like congestion, where you may want to rule off endophthalmitis. Look closely for any demon detachments and any sort of inflammation in the AC which is causing the corneal edema. Also, do look for retained matter, especially in the inferior fornix when it is a retained cortex and nucleus matter. A few tips for a good slit lamp examination is if the corneal edema is not allowing a good visualization of the DM detachment, you could always dilate and have a look at through retroillumination, where even a small DM detachment may become obvious. Always use a high illumination and a good slit view to pick early DM detachments or small DM detachments. Glycerol again can help improvise the view, but that is not to be used immediate post-op in view of avoiding infection. So clinically, it's very important that you differentiate between a TAS-related corneal edema and end-of-related corneal edema. So TAS usually has limbus to limbus edema with minimum pain, diffuse fibrinous AC reaction, sometimes can have iris atrophy and trabecular meshwork damage as well. So the gross differentiating factor between both would be absence of vitritis in TAS and the presence of this same along with vitreous exudates and loss of red glow in the case of endophthalmitis. So the next important tool would be the OCT. So this is how a normal OCT of the cornea looks. It is of extreme value, especially if you want to differentiate between a DMD associated, that is a Descemet's membrane associated edema, and non-Descemet's membrane associated edema. And I will be discussing this in further slides as well. Specular may not be helpful in the area of edema, but certainly a specular of the other eye can help us pick a missed fuchs or endothelial dystrophy, or even the clearer areas of the affected cornea. A specular can help to diagnose a missed entity on the endothelium. Again, pachymetry, a global pachymetry, especially by an OCT device, is extremely helpful, especially if you're following up a case of post-op edema and you want to see if it is improving or no, especially when you're trying to plan a lamellar keratoplasty for non-resolving edema. Again, do not rely on optical devices like Pentacam, as with the edema, their accuracy is not great. Now, coming to the management, for decades we have been using the hyperosmotic agents, the hypertonic 5% drops and a 6% ointment. Again, they are useful, especially for symptomatic relief. An ointment at night may be very comforting to the patient when he gets up in the morning. Again, a bandage contact lens can be used, but should be used carefully, because this is a post-operative patient and you have steroids, and a BCL can be used only in cases of symptomatic patients. Now, other medications would be an anti-glaucoma medication, because you would want the IOP to be low, as an increased IOP itself can delay the endothelial recovery. Make sure you avoid prostaglandins and also avoid carbonic anhydrase immediately post-op when you have a corneal edema. Again, steroids have to be used generously after you have ruled out an infective etiology, and inflammation has to be controlled, because that helps the endothelial to recover much quicker. Other adjuvant agents like cycloplegics and NSAIDs are extremely helpful. There is lots said about the ROCK inhibitors, so we could try natrasudil and ripasudil. There are a lot of papers now proving their efficacy in post-op corneal edema as well, due to their cell proliferative cell adhesion action, and also as they suppress the apoptosis. Now, TAS again a special mention. This basically TAS, as we know, is because of poor technique of sterilization, contaminations in your fluids or an OVD or preservatives. So always ensure you use preservative-free medications, ensure adequate and cleaning and sterilization protocols, and use disposables when possible. And again, TAS has to be managed by judicious administration of steroids. Now, coming to the surgical management, again, a DM detachment is something you have to intervene quickly if it is especially large and central. These are a few risk factors for DM detachment. So, as I mentioned earlier, OCT has an extremely important role while managing a DM detachment. So, here you beautifully see the DM detachment along with the split Duas layer as well. So these raster scans can help you analyze this entire area, and this is the culprit here. So this is a corneal incision which has caused the DM detachment, and further you go, you also can see the Duas layer. So this is extremely important in diagnosis as well as planning. So these are various ways in which a DM detachment can be classified. Again, a lot of protocols like the HELP protocol, which help us decide on when to intervene and how to intervene in cases of DM detachments. So the gold standard for early management of DM detachment is intracameral gas or expansile, non-expansile air injections. So in red, I've highlighted how to prepare the required concentration. So a few surgical tips when you're planning an intracameral injection would be you could try glycerol for better visibility. Always have a dilated pupil, because the retroillumination will help. A light pipe also can be helpful. Make sure you use sharp instruments. Try to do a peripheral iridectomy, and always enter through the non-detached area. So this means these are three profiles of different types of DM detachment. So up is a planar DM detachment. So here you can inject either from the nasal or temporal area, it's safe. Now this is the detached area in the second profile. So try not to enter your needle from the detached area, as if air or gas is injected here, you would cause more worse and better to the patient. So in this patient, you can't do nasal or temporal, so you plan a superior and inferior entry. So again, in the third profile, do not do here where you have a DM which is open, but try to enter from the opposite side. So there's a lot of good work by Professor Harminder Dua in this regard as well. Now, if nothing works, your medical management doesn't work, and if the endothelial damage is too severe, then you would have to plan a lamellar corneal transplant, which could be a DISEC, PDEC, or a DIMEC. So with today's advancements of corneal surgeries, there's a very limited role of a full thickness corneal transplantation in post-surgical endothelial loss or edema. So to end it with, I would say post-operative edema, there is a range of causes and pathogenesis, and there can really not be a fixed protocol. So the best way would be to see what is causing the edema and diagnose that, and then have a targeted therapy to treat the exact cause. Thank you so much.
That was a wonderful presentation, Dr. Deepthi. I'm Nagaraju, sir, ophthalmology mentor Institute of Ophthalmology. We'll be talking on Rhexis issues, a great teacher for all of us. Over to Dr. Nagaraju, sir.
Good evening, everybody. I would like to speak on the Rhexis issues, what we usually face with small incision cataract surgery All of us know that the ideal Rhexis requires a deep anterior chamber. The iris plane should be parallel to the microscope plane while executing the Rhexis, good magnification, and whenever possible, a good coaxial illumination and a red fundal glow. In case of opaque cataracts, we might require assistance while executing the Rhexis with viscoelastic devices, dyes, oblique illumination, forceps, Vanna scissors in case of fibrotic capsules, or support to the capsule during Rhexis, either using a iris hook or a capsular tension ring. Now, the capsular small incision cataract surgery is an intercapsular procedure wherein the cataract has to be removed from the capsular sac, keeping the Rhexis margin intact, and it requires a lot of modification. The Rhexis in SSS is usually larger compared to a phaco-Rhexis, and usually it is more prone for capsular radial tears because sometimes we might go close to the 7 millimeter zonule free zone in the anterior capsule, and though the capsule can stretch up to 1.6 times, sometimes we require a fairly large access while for the nucleus delivery. And this is what we usually face when we try to execute a Rhexis. When we try to make a Rhexis, we might end up having a radial tear. So what all modifications you require? And in the case of a small pupil, it might be more difficult to do a Rhexis if you just don't use any assisted devices. Here you see the Rhexis is being fashioned, but in the end, we finally ended up doing a canopal capsulotomy. So what are all the various modifications we have to do while executing the Rhexis? A deep anterior chamber is ensured by using adequate amount of either a cohesive viscoelastic or a dispersive viscoelastic, a cystitome. Here you see the Rhexis is being made, the chamber is deepened, and whenever the chamber shallows, you can use additional viscoelastic. And in the case, and try to make, in this case, the pupil is small, sometimes you can just run the Rhexis behind the pupillary margin and look for the hump near the iris while doing the Rhexis. Here the Rhexis runs off, almost 3/4 of the Rhexis is completed, and still you can salvage the Rhexis by making another cut there and completing the Rhexis. Or sometimes you can do a spiral capsular Rhexis by making another cut all around. Most of the cases requires assistant with a dye, especially in the case of opaque cataracts, and sometimes you require a viscoelastic, which is a cohesive one, to prevent this escape of the viscoelastic from the anterior chamber. Here you see the Rhexis being done with a cystitome. Chamber is formed whenever the chamber shallows, and the Rhexis is completed. In a mature cataract, sometimes you can use an oblique illumination also. In the case of an hypermature cataract, or in any cases where there is an increased intralenticular pressure, you can just make a small nick in the capsule, drain out all the fluid, decompress the lens, decrease the intralenticular pressure, inject more viscoelastic, and then you can complete the capsular Rhexis. Ideally, it is better to use a capsule forceps, a micro forceps, whenever you try to do a Rhexis in a hypermature cataract or an intermittent cataract. Here you see the Rhexis micro forceps being used to make a very good Rhexis, and in this case, a cohesive viscoelastic substance was used. In cases where the pupil is very small, you can try to dilate the pupil either by using a pupil dilating device or usually using pupil expanders. The commonest and the cheapest one is an iris hook. You can retract the iris, stain the capsule, and you can fashion out the Rhexis. Rhexis is the important step in any cataract surgery, more so in SICS, and an adequate large Rhexis is always compatible with a small SICS. And usually the size of the Rhexis depends upon the density of the cataract. Thank you. Mr.
Hello, doctor, can we move on to the next?
Hello. Yes, Karthik.
Yes,
We
doctor.
can move to
Can we
next
move on to
presentation.
yes, doctor. Next is Dr. Praveen
The
Alwani.
next the next the next presentation would be by Dr. Praveen Alvandi, who will be speaking on zonular damage. He is a Chief of Clinical Services and Chief Surgeon in Agarwal Hospital, Dr. Praveen.
Good evening, everyone. At the outset, I would like to thank COSCON Organizing Scientific Committee for inviting me for this talk. The topic given to me is zonular damage during cataract surgery. Zonular damage happening during cataract surgery or either as a pre-existing condition is any cataract surgeon's nightmare. We need to understand the condition, prepare ourselves preoperatively, and also equip ourselves with required skills and the necessary implants to be able to give successful outcomes in these cases. Let's look at the etiology first. There are certain conditions which predispose to zonular damage: pseudoexfoliation, traumatic cataract, advanced age, ocular neoplasms which have been operated, aniridias, lenticular colobomas, hypermature cataracts, retinitis pigmentosa, conditions like Marfan's, Weil-Marchesani, Ehlers-Danlos loss, lens colobomas, iatrogenic conditions which can cause zonular damage is difficult Rhexis, undue pressure on the nucleus while maneuvering it out of the bag, pull on the Rhexis rim while delivering the nucleus, post-vitrectomy cases, post-intravitreal injections. Let's look at the pathophysiology. Zonular fibers, also known as the zonules of Zinn, originate from the basal laminae of the non-pigmented epithelium of the ciliary body and get inserted into the lens capsule at the equator, 1.5 mm anterior and 1.25 mm posterior to the equator. They are about 5 to 30 microns in diameter and about 140 fiber bundles, made up of fibrillin, which is a glycoprotein coded by the FBN1 gene. For diagnosis, we need to take a careful history, elicit history of trauma, look for systemic abnormalities, family history. Some patients may also complain of monocular diplopia. Thorough slit lamp examination on a dilated pupil will reveal compromised zonules. Case of Marfan's with superior subluxation and extensive zonular loss. Case of lens coloboma here with a notch in the lens. Slit lamp examination may reveal pseudoexfoliative material on the lens capsule, subtle phacodonesis with vitreous herniating into the antechamber, calcified capsule in hypermature cataracts. Look for the degree and the number of clock hours involved. It helps us plan which type of implant will go in. Do a gonioscopy tension applanation and a dilated fundus exam to rule out pre-existing glaucoma. Telltale signs of a compromised zonule. Whenever we initiate a Rhexis in compromised zonules, there is this wrinkling of the anterior capsule, which is a telltale sign that the zonules are not very healthy. There is inability to complete the Rhexis or non-rotation of the nucleus after hydrodelineation. What are the options available? We have the capsule tension rings, Sioni tension rings, the Ahmed segments, and the glued capsular hooks. There are different types of CTRs available. The regular CTRs with eyelets here. We have the Henderson rings here. We have a Sioni ring with a comma-shaped loop. There's this Ahmed segment and the glued capsular hook. Indications for capsular tension rings: mild zonular instability, less than 4 clock hours. We can use a CTR. Mild phacodonesis, cases of pseudoexfoliation, and slight Rhexis ovalization after CCC. Prerequisites for CTR implantation is you need to have a proper CCC with intact Rhexis and no PC rent. Capsular tension rings are open-ended 270-degree rings made up of PMMA filament with 2 eyelets on either end. Sioni rings are just a modification of CTRs. They have additional hooks at the sides. They come in different models with single eyelet right, single eyelet left, or double eyelets. Capsular tension segment. This was designed by Ike Ahmed in 2002. It's a zonular support device for extensive subluxations and it provides support for in-the-bag implantation and scleral anchorage. It is versatile and allows us to implant early or late within the capsular bag and can be used in cases where CTRs alone cannot support the capsular bag. Advantages are they cause a uniform circular expansion of the capsular bag, stabilizes the capsular bag during surgery, improves IOL centration, reduces the risk of capsular fibrosis, and resists capsular phimosis. Sizes which are available, you have 12 mm open diameter, compressed diameter to 10 mm, which can be implanted in shorter eyes, 13 with a compressed diameter of 11 mm, which is the commonly used implant for moderately long eyes. For extremely long eyes, myopes and all, you use 14 to 12 mm larger rings. Technique, either a two-handed technique using forceps, a microforceps, or two Sinskey hooks, or you can use a goiter injector. This is the goiter injector, single-handed technique. Let us look at certain clinical case scenarios. Here is a case of chromatic zonular compromise. You have around 3 clock hours of zonular loss and a D-shaped ovalization of the rhexis. These cases you can just get away without even implanting a CTR. Just put a good single piece acrylic IOL in the bag with the haptics abutting the area of the zonular loss, and you'll achieve a very good centration of the IOL. Certain cases require CTR implantation. Here's a video which shows implantation with the help of the forceps. You can note the area of the zonular loss here and a D-shaped rhexis. First, fill the capsular bag with an OVD to inflate the bag, and then implant the CTR facing the zonular dialysis first. Never implant it away from the zonular dialysis because you're going to extend the zonular dialysis. Smoothly, the ring glides into the capsular bag. The forceps is being used here to implant the CTR. This is the leading end. Now the trailing end is taken, and then make sure you tuck it into the capsular bag. This is followed by implantation of the intraocular lens. Nicely centered intraocular lens is attained at the end of the surgery. What are the take-home clinical pearls for CTR implantation? First and foremost, always implant towards the side of the dialysis, never away from it. Whenever you are implanting in small pupils and you're not able to visualize the rhexis margin, always use iris retractors, visualize and then implant. Don't put the CTR blindly. It may end up in the sulcus or it may go into the vitreous cavity. For beginners, better is you use microforceps for implantation. You have more control over it. But for experienced hands, two Sinskey hooks can be used, and equally well, they will help you implant the CTR. Always release the CTR in the bag. The dictum is implant as late as you can, but as early as you must. And for very large subluxations, always use scleral fixated capsular support rings or glued capsular hooks. Here's a video of the Ahmed segment implantation. This is the original video by Ike Ahmed himself. Pre-threaded hook with a Gore-Tex suture is implanted into the capsular bag. A Hoffman pocket is created here. A slip knot is applied, and the tension on the slip knot is adjusted so that the bag is centered. You don't tighten the knot immediately. This is followed by injecting a CTR by the help of the goiter injector for additional capsular support. Once it is in, you tighten the knot here. And then once the bag is stabilized, you implant a single piece acrylic lens. Finally, when you see the lens well centered, you make the final adjustment and tie the knot. This looks somewhat like this at the end of the procedure. The only drawback with this is long-term stability. The sutures may get dissolved. Hence, you may require a redo surgery. That's the reason Dr. Susan Jacob from Agarwal Eye Hospital devised the glued capsular hooks. Here, scleral flaps are made at the site of the zonular dialysis, and capsular hooks are engaged and buried into the scleral groove. This is extensively subluxated cataract. Here, we create a scleral flap, do the Rhexis. A scleral window is done with the help of a 20-gauge needle. These are specially designed hooks here. You bend them at 90 degrees for easy manipulation into the scleral window. And with the help of forceps, go through the scleral window, underneath the iris, engage the capsular rim. You can use a micro forceps to guide the tip of the scleral hook and engage the rim there. Once it is engaged, use a stop, silicone stop, to stretch the capsule and center the capsule. An additional CTR is implanted for additional support. And in this case, additional hooks at the limbus are implanted for supporting the capsular bag for nucleus removal. Once the cataract is removed, you place a single piece lens into the bag, make a scleral groove, remove the silicone stop, trim the hook and bury it in the groove which you have created. The additional hooks can be simply removed out. Well-centered intraocular lens is achieved. These flaps are closed with the help of fibrin glue, and you get a very good centered IOL. To conclude, there is no clear winner. Multiple options are available. Anatomy of the eye, ocular pathology, associated conditions, visual potentials should guide the proper technique. Every surgeon must be adept at several different techniques and be able to choose the best procedure for the given condition. Thank you.
Thank you, Praveen. That was a good presentation. I now invite upon Dr. Mallikarjun Hiralgi, sir, who is the Chief of Cornea Department, Head of the Refractive Surgery Department, Shankara Eye Center, Shumaga, a great teacher. Over to you, sir. He'll be speaking on iridodialysis, how to prevent and manage in SICS. Over to Mallikarjun, sir.
Hi everyone, I am going to talk on iridodialysis causes, prevention and management in the SICS. Most commonly it happens during nucleus delivery. When you engage the nucleus along with the iris and pull it out, it may lead to iridodialysis. And if you have a premature entry and there is iris prolapse, repeated manipulation might lead to iridodialysis. And the delivery of nucleus through a small tunnel. What happens if you're delivering the big nucleus through a small tunnel? It would press on the iris, and when you're delivering, it might come through, leading to iridodialysis. Sometimes accidentally, you might pull the iris while doing cortical aspiration, especially when the cortex is below the iris. Recognition of iridodialysis is very important because if you recognize it early, you might reduce the further damage of the iridodialysis. If there is unexpected bleeding into the antechamber, especially after nucleus delivery, there might be a iris injury or iridodialysis. And if you have iris prolapse, you might directly see, you can see the root of the iris in the tunnel. Sometimes you can see the root of the iris in the antechamber. The pupil size may alter. It looks like a D shape. So These are all the ways to recognize the iridodialysis. How to prevent iridodialysis? Use sufficient amount of viscoelastic above and below the nucleus when you're doing nucleus delivery, and make sure that you are engaging the only nucleus with your wire vectors or any other instruments you are using for nucleus delivery, and not engaging the iris. Suppose you engage the iris along with the nucleus. When you're pulling it, you have to look at the iris. If the iris is also moving along with the nucleus, there might be a you might have caught the iris and nucleus. So you should stop immediately and um, push viscoelastic below and above the nucleus and deliver the nucleus carefully. And if there is iris prolapse, you have to manipulate it very carefully, and the length of the tunnel should be very appropriate depending on the size of the nucleus. Cortex aspiration should be very careful, especially when you are removing below the iris. Management depends on the situation. You can go ahead with primary procedure if there are no complications and the visibility is good, there is no bleeding, cornea is clear, and you are able to do the nucleus delivery, implant the IVL, and same sitting you can repeat the iridodialysis. Suppose you have other complication along with iridodialysis like PCR, vitreous loss, it is better to wait for some time. During that situation, do a good anti-vitrectomy and make sure there is no vitreous strands near the tunnel or the side port, and close it, and you can take up it as a secondary procedure. During that waiting period, you have to adequately treat the inflammation and secondary glaucoma. There are many surgical methods of iris repair have been described, like Kobler's technique, two-fold technique, mechanical suture, handbag technique, two needle technique, sieving machine technique, and riveting technique. This technique we have been doing recently. This is iridodialysis in pseudophakia. First, I make a conjunctival peritomy adjacent to the iridodialysis and make a groove in the sclera and pass a bent 30 gauge needle through sclera into the antechamber and then using a vitreous microforceps, I engage the detached iris to the 30 gauge needle gently push into the iris tissue and with the microforceps bring it outside the iris. Now using the 6-Europrolene and threading it into the barrel of the needle. And externalize the 6-Europrolene. This is a low temperature cautery. Make a flange by heating it and pull it so it will anchor the iris, and the other end cut the Prolene suture and pull and make a flange by heating it so that iris is pulled to the root and it is attached. And then close the conjunctiva either with suture or fibrin glue.
Go to the next presentation. PCR management by Dr. Deepak Megur.
Dr. Deepak Nagaraju has shared only one video.
I'll be presenting from my laptop.
Okay, doctor.
Good evening, friends. Thank you for the opportunity. I'll be speaking on management of posterior capsular tear. I'll be just sharing a brief overview of some basic principles I'd like to touch in. This is a complication which is often avoidable. Although it's inevitable in the lifetime of a cataract surgeon, we'll see many PC tears, but the understanding of the principles and newer techniques, it's possible that we can reduce the incidence of PC tear to bare minimum. So it's a highly avoidable complication, and when it happens, we need to ascertain that the war needs to be won, although the small battle is lost here. The first thing I would like to for an younger surgeon to address this is he has to address himself or herself, saying that I would not want to do anything much more worse than this, because believe me, things can go downhill from here. So I think it's better if we are well prepared whenever we have a complication like PC tear. Better to have certain goals and principles. I would like an younger surgeon to have these 6 goals of management of PC tear, which I personally will follow. The first goal always would be to diagnose this PC tear early. If you can diagnose it early, half the battle is really won. And the problem really is, diagnosis is significantly delayed, and that's the reason we lose a lot of opportunity wherein the consequences could have been still better. The principle is we need to diagnose early. We need to have a high level of anticipation, and also better microscope does help. But believe me, if we have an overlying nucleus, the diagnosis becomes even more challenging. The next principle of the goal would be to prevent nucleus drop if the nucleus is still present. This is particularly referable to phacoemulsification, but even small lesion cataract surgery we can have, although very rarely, and that should be our first goal. And if we can diagnose this PC tear early, we can always try to prevent rupture of the anterior and vitreous prolapse. So that has got a great impact on the outcome of the vision. So that should be our priority, and that should be the reason why we want to diagnose it early. And again, if you can diagnose early and take adequate measures, we can prevent enlargement of the posterior capsular tear. If you can prevent enlargement of the posterior capsular tear, we have an opportunity to place the lens in the bag itself, so without altering much of any technique. And of course, if vitreous is already prolapsed, then it needs to be dealt with appropriately. And finally, if we have followed all the 5 steps meticulously, we still have an opportunity to place the lens in the bag. In worst case scenario, we can fix it in the sulcus. Of course, if you have lost the bag or if the tear is too large, then we can think of iris fixation or scleral fixation of the lenses. And of course, AC lens can also be placed. So early diagnosis is extremely critical, and as I was telling, diagnosing it early becomes difficult if an overlying nucleus is there. So whenever we have a nucleus which tilts, even in SICS case, when you do a hydrodissection, nucleus is tilting like this something, then it is an ominous sign, and we need to be careful about this. And always try to push the nucleus to a side and try to visualize the posterior capsule if possible. And in this case, we could diagnose the posterior capsule tear very early and immediately extend the incision, pull the nucleus out, and the nucleus drop could be prevented. The next most important aspect would be whenever we have a rupture PC tear, we don't want to rupture the anterior and vitreous prolapse, and also prevent enlargement of PC tear. Just like to demonstrate in this small case, and cortex aspiration is probably the most common step where PC tear happens, and this is where a PC tear has happened. It's a small round oval structure presently, and now the goal is not to enlarge this PC tear, not to rupture the anterior hyaloid. The first thing is we don't want the chamber to shallow, so before coming out, inject OVD into the chamber so that the chamber equilibrium is not compromised. And once the chamber is maintained, you can remove the irrigating Simcoe or irrigating handpiece. In this case, because the cortex was already aspirated out, I just went in ahead and put in the lens. Now the important thing is, how do you remove the OVD which is gone behind the lens as well? One option is simple, is just leave it alone and can just absorb, pressure spikes will be there. But if you can maintain a very low bottle height, or if you're using a Simcoe with a bulb with very low pressure, with gentle irrigation, you can just go ahead and wash the viscoelastic behind the lens as well, without enlarging the PC tear or without rupturing the anterior halide as well, as was evident in this case. So the message here is that, maintain the chamber equilibrium when you note the PC tear at the earliest really helps us to prevent the rupture of the anterior halide. We can see that the triamcinolone acetate has gone into the Burger space, but it has not. There is no evidence of any rupture of the anterior halide. There is no vitreous prolapse. So this is conclusive that we don't have vitreous prolapse. So it makes sense for us to confirm with a diluted triamcinolone acetate at the end of your case. And this is another classical case, when you have a post-occlusion surge in phacoemulsification, you have the PC which is getting caught here, and we have a post-capsular tear. Again, the same principle is to be followed. You want to put in the OVD without removing the your irrigation handpiece. As a reflux, we will just have a tendency to remove it, but if you can do that, when the sudden shallowing of the anterior chamber does not happen, we can always maintain the anterior halide phase. Dry aspiration of the remaining cortex heads can be tried, as I'm trying here. Sometimes it works and sometimes the aspiration port gets clogged. Might be difficult, so again I'm using irrigation, but again look at the bottle height. The bottle is at just 30 centimeters. If you can maintain a very low bottle height and very gentle aspiration, even with irrigation on, we can do cortex aspiration even in presence of a open posterior capsule without rupturing the anterior hyaloid. And again, you can go ahead and implant the lens into the back without rupturing the anterior hyaloid. And also you can go ahead and remove the viscoelastic which is behind the lens as well. So again, the take home message here is, gentle irrigation to remove the OVD or to aspirate the cortex. We can manage this if you are able to maintain a closed chamber. If you're doing SICs, I think using just the side port with gentle irrigation would ensure that your chamber doesn't fluctuate much, and you can gently remove all the viscoelastic which is gone behind the lens as well. Now moving on to my last case. So you could see that the end of the surgery, we could manage to remove the cortex, the OVD, everything, and without enlarging the, of course, the shape of the tear did help. It was like a posticapsular Rhexis. Now this is a 10-year-old boy who has got a traumatic cataract. The anterior capsule is ruptured. It is wide split, wide open. And he is an 8-year-old boy, so we don't expect any nucleus in this. As a soft lens matter will be there. I don't know the situation of the posterior capsule, but once the cortex is aspirated, I can clearly see that the posterior capsule tear is present. It's quite a large posterior capsule tear, but something tells me that the anterior halide could still be intact. So without removing the irrigating handpiece, I'm just trying to push in OVD first to maintain the chamber. Now I would want to confirm whether the vitreous prolapse is there or not. So I'm just trying to put in some diluted triamcinolone acetate to check. The anterior halide face seems to be stained, but there is no prolapse there. So that is an encouraging sign suggesting that the anterior halide face is still intact. So I'm going ahead and trying to implant a multi-piece lens into the bag itself. And if you could maintain the chamber throughout, we could manage the case even with an open posterior capsule without maintaining the anterior halide face. So I'd like to conclude my talk by saying that PC tear and anterior halide rupture are two different independent entities, and if you can spot the PC tear early enough and we can take adequate measures, these two are important independent entities. So they don't have, anterior halide need not be always be ruptured when you have a PC tear. It can be prevented. The message here is you need to diagnose PC tear early enough. If we can take adequate measures, then we can prevent the vitreous from prolapsing out. Of course, the secret is, you need to maintain the chamber equilibrium. That is the most important secret. We need to avoid sudden deepening and sudden shallowing of the chamber. So both are detrimental. Sudden pushing in viscoelastic, sudden deepening, as well as sudden shallowing. So if you work with low bottle height, low flow rate, low irrigation fluid which is going inside, we can maintain certain amount of calmness in the chamber, and that can prevent the PC tear from enlarging. Of course, using a dispersive OVD, something which contains chondroitin sulfate, has a great role in maintaining the chamber, as well as it acts like a barrier. So essentially compartmentalize the department, and hence we can prevent sudden or forceful entry of irrigating fluid into the posterior chamber, into the and rupture of anterior can be prevented, and thus consequently vitreous prolapse can be prevented. I think with that I would like to stop my presentation. Thank you so much for attention.
We have just finished the second session on time. Now the last session is the advanced MSSES.